What does the data say about the value to patients? I mean, you just quoted
Mhm.
that it's just shocking, just arresting statistic about how patients are dying because they don't have this information. But what is the literature in terms of like treatment outcomes and costs say about PGX testing?
Great question. There was a wonderful study that came out of Europe called the Prepare Trial. It was published in Lancet about a year and a half ago, I think now. And this looked at panel testing in several European countries and all sorts of different care settings: cancer care, mental health care, primary care, in pharmacies. And the trigger was just, hey, we're about to give this patient a drug, and there are a lot of them that could be impacted by pharmacogenetic guidance. And so we would recommend a drug or a dose change if they had a certain liver highway variation, so to speak. And in just 12 weeks, they saw a 30% reduction in clinically significant adverse drug events. And that was across all of these different settings. Importantly, in cancer care, and I imagine a lot of your listeners may be battling cancer or caring for somebody that's battling cancer. They didn't count it as a significant adverse event unless it was stage 4 or stage 5. Stage 4 is severe or life threatening, can hospitalize you, and stage 5 is death. They still saw a greater than 30% reduction in clinically significant adverse drug events in just 12 weeks. I've also personally co authored studies that have shown dramatic reductions in emergency room visits, hospitalizations, saving $1,100 to over $4,000 per patient, depending on how acute the care setting was, in well under a year.
So over $4,000 cost savings, 30% reductions in adverse events, keeping people out of the hospital, um, not increasing the cost of care by having to go to the emergency room. I mean, who's responsible for introducing this conversation to patients? I mean, what doctors should be responsible, because obviously the application of this genetic information can be in any disease.
Yeah. I think that's part of what we've run into in terms of barriers to adoption. This same set of genes, these same liver highways, impact drug response across all sorts of clinical areas. So, if a cardiologist orders a test, it has implications for mental health medications and pain medications. And so, I think there's been some resistance to the information because of the broad impact. But the ideal healthcare provider to I would say make this part of the standard of care is pharmacists.
Mm.
Pharmacists go to school just as long as medical doctors, and they have 5 times the coursework in pharmacology. They are very well versed to take this on. The issue is, unfortunately, um, decades ago they required less education, and federally they're not recognized as healthcare providers. So a nurse practitioner PA has more payment and recognition, even though they have less schooling or training than pharmacists. And that has created some issues with uptake. I think one of the biggest reasons that we have such catastrophic increases in healthcare costs without seeing improvements is the fact that we are not helping that profession practice and get paid at the top of their scope of practice. But those are the specialists, and um, there are instances in which they can be leveraged in more and more states. So, states, for at least commercial and Medicaid, can say, hey, these should be healthcare providers and we should pay them like other healthcare providers. And that's very much helping. But I would say that people should talk to any of their providers that are giving them medications that are impacted by pharmacogenetics. If you Google CPIC, the Clinical Pharmacogenetics Implementation Consortium, but just CPIC, drug gene, it'll pull up a list of all of the medications that have drug gene interaction guidance. Anything that says A or B, that means there are recommendations to change a drug or a dose if you have pharmacogenetic information. People can go look for their medications there. I'm happy to provide a list of medications by different specialties that you can use to optimize drug and dose selection. But patients should be advocating for themselves. If you can afford it, even if you have to pay out of pocket, talk to a pharmacist. Like, it could save you hospitalization, emergency room visit. The cost differential is very low.
That's why this conversation is important for listeners, I believe, Kristine, because when we're talking about patients on medications and trying to optimize and know for ourselves which medications are going to be best for us.
Mhm.
Statistics here, right? So there's 45 million patients, estimated 45 million patients in the US that are taking 5 or more prescription medications. Think about the not just the gene drug interactions, but the drug interactions. And many of those patients are on those medications because they have concomitant illnesses. So you have cancer patients, many cases are on psychotropic drugs, right? So
Mhm.
I think this is just uber important.